Dr. Shelly-Anne Lee to the podium to start the competencies consensus items.
Thank you, Serap. All right, so it's time for competencies. There's 15 of them. You just heard 7 of the research priorities for outcomes assessment. So I hope you're ready for the competencies. While more training programs are emerging for healthcare professionals who care for musicians, there's still a major gap. There's no consensus-based set of core competencies to guide what providers need to know and be able to do in this specialized area. When we talk about competencies, we're not just referring to the clinical knowledge and the technical skills. Competencies also include broader abilities like communication, collaboration, and getting us to think constructively about how healthcare professionals function effectively within complex healthcare systems, and that we may not even recognize the unique needs of musicians. So that takes us to our preliminary findings of the scoping review, which highlights just how much this specialized area of care really is. It shows that effective care for musicians require a unique blend of 2 main things: specialized knowledge, so like understanding the musician's context, their interaction with the instrument, and the biomechanical demands of performance. And then number 2, the specialized skills, including clinical reasoning, collaboration across disciplines, and building therapeutic relationships. So without a unified competency framework, training remains inconsistent, and care continues to vary based upon individual experiences or interest. This is why developing a global, expert-informed set of competencies is so essential for us. Sorry, I'm moving backwards. There we go. All right. As we heard from Anna, we've held over 60 hours of convergence meetings with 105 international experts and more than 12 hours of consensus-building meetings with our steering committee. All of this was also grounded in the preliminary findings of our scoping review, which helped us generate a list of 15 consensus items. We recently just completed round 1 of the 3-round Delphi process, and we're excited to report the results at the conclusion of this presentation. The remaining 2 rounds of the Delphi process, which will take place in the summer and the fall of this year, will help us refine and strengthen agreement of each item as we move forward to finalize the competency framework. I'm trying to click. There we go. So now I invite Darin Atwater to the podium to present our first consensus item. Thank you.
Thank you. I'm so honored to be here to sort of add from a musician's perspective. And I just want to take a moment to talk about the real world experience of being a musician, not just what we do, but what we carry. It's easy to see the art, the performance, the finished product, but behind all of that is a world that affects our health in ways that are often invisible and rarely acknowledged. The peer pressure is real. Musicians live in an intense environment to be perfect. I like to use the analogy that if a baseball player is 7 out of 10 in his career, he's in the Hall of Fame. If a musician misses a note or 2 in a concert, it's almost career suicide. I mean, this is intense pressure to be perfect. And not only that, the repertoire demands perfection. Specifically in the canons of jazz, classical, of American popular music. If you've heard Beethoven 5 a million times, the 5th concerto, Emperor Concerto, and you hear someone play it and it's been played for 350 years, just the pressure behind the gravity of that repertoire. Or if you're a cover musician playing in a bar and you're playing The Piano Man by Billy Joel, everybody knows that blues turnaround. So this sort of the psychological pressures inherent in the music. There's no room for error, and we're also competing and collaborating at the same time, all while hiding injuries and or pushing through pain. We play in spaces that weren't built for health a lot of times. This is the environments that strain health. From orchestra pits to clubs to outdoor stages, the places we often work in are often putting our bodies at risk. There's no health infrastructure around us, no way to diagnose overuse, and no built-in support for healthy practices. We just adapt or break down. And then we're valued by the market and measured by the trend. We're often judged by how well we fit into trends and not how strong our artistry is. It's not just, are you good? It's, are you relevant? This constant chase of commercial appeal can wear people down and make it hard to stay true to yourselves. Jazz artists are seen in the same light as a pop artist. There's this attention economy where visibility and followers are more valuable than depth and nuance. This creates a big problem for artists who are sort of niche artists and trying to occupy a space that's really not popular in its essence. And then there's the multiplicity of roles: teaching, performing, rehearsing, recording, networking, promoting, often in the same day. We're no longer artists, we're artist entrepreneurs. Add in family, friends, and community, and the mental and emotional juggling gets very real. And let's not forget, again, social media. Keeping up with these ideal versions of ourselves online can take a toll, especially when we're struggling behind the scenes. And lastly, it's financially and emotionally heavy. Many musicians work gig to gig without a steady income or health insurance. And yes, there's a lot of freedom in that, but it's not sustainable. That kind of uncertainty builds stress over time, and we don't talk about it often enough, especially in clinical spaces where it matters most. I just want to go off script really quickly. I'm a composer, pianist, conductor, and I was in Nepal speaking at a global conference, and I had an accident and tore my UCL on my thumb. Had major surgery to reconstruct it in January. Serap was one of my occupational therapists, physical therapists, and it shut down my life completely. Everything that I do, conducting, performing, sort of my social interacting, networking with the orchestra that I conduct, my students. I'm a professor at Peabody. So I know firsthand what it takes to sort of re-engage and reignite not only the passion that you had, but also the skeletal, the muscular aspects of it, the physical aspects of sort of returning to play, which is probably about 6 months to a year for myself, having canceled conducting opportunities across the world. So this sort of care and nurturing and information and infrastructure, it's been so vital to my own personal journey. So I'm not just here to speak, but I'm also here as an advocate for millions of musicians around the world. If we want to provide real care for musicians, we must understand that the world that we're surviving in, physically, emotionally, and financially. Because until we treat the context as seriously as we treat the condition, we're not addressing the full human behind the music. Thank you. I'd like to invite Michelle King and Nikolai Klotchkov to the podium.
When we talk about musicians and their instruments, it's not just about the notes they play. There is a whole physical relationship at work, something we can think of as the musician's interface with their instrument. This interface involves how the musician's body moves, their posture, the weight and size of the instrument, the space around the musician, and even the costumes they wear during the performance. Why is this important? Because musicians often must explain their setup and physical needs repeatedly to healthcare providers, doctors, therapists, and other specialists who might not fully understand the demands placed on a musician's body. This constant need for explanation isn't just frustrating, it's insufficient and can delay proper care. Additionally, specific knowledge such as a surgeon knowing musician's finger placement before planning an incision can be the difference between a successful surgery and the end of a musician's career.
Breaking the musician's interface down further, we can identify 5 core elements. First is posture and setup. Think about a violinist. The way their chin rests on the instrument, The height of the music stand, the chair they sit in, all these influence comfort and performance. Ergonomic considerations here are essential to prevent injury. Second, biomechanics and movement. Different instruments and musical traditions require unique body mechanics. A classical guitarist uses very different positioning and setup than a folk or a rock guitarist. Understanding these nuances help tailor care to each musician's needs. Third, the instrument itself. The size, weight, portability, and how sound is produced. Carrying a double bass is a completely different physical challenge than playing a tiny piccolo, and healthcare providers should appreciate those differences. Fourth, the environment and context of the performance. Musicians navigate spatial relationships with conductors, fellow performers, lighting setups, and the acoustics of the space. Imagine the cramped confines of a pit orchestra or the glare of the stage lights. These factors influence how a musician moves and feels during a show. Finally, repertoire and physical demands. Playing a fast-moving concerto creates different physical demands than a slow lyrical piece. Additionally, musicians often perform in costumes, uniforms, or even engage in choreography that adds to their physical exertion. Playing in a marching band or on a crowded stage comes with unique physical challenges that must be recognized.
Given all this, the recommendation is clear. Healthcare professionals should have a comprehensive understanding of how musicians physically interact with their instruments and the environments in which they perform. This knowledge is essential and should be incorporated into core medical competencies. When providers understand the musician's physical interface, it reduces the burden on musicians and leads to more efficient, empathetic, and effective care. Next up is Dr. Christine Guptill for item number 3.
Hi, this is Christine Guptill again, Associate Professor at University of Ottawa, occupational therapist and oboist. I think many of us understand that what musicians do is unique and complex. To be able to sing or play an instrument requires specialized skills. Repetition is certainly involved, whether it's repeating sections of music in the practice room in order to learn the music, or whether it's repeated movements required to sing or play certain notes or passages. Many of us would like to see services for musicians expand to people who might normally only see athletes or ears, and expand to people who are generalists like family doctors. So it might seem a tall order to say that healthcare professionals should develop an understanding of the muscular, skeletal, neurological, and psychological health of musicians. So let me clarify that what we are recommending is that everyone who cares for musicians should understand that these factors intersect and influence each other. For example, if a percussionist breaks their elbow falling off their bicycle, I hope the orthopedic surgeon operating on their elbow understands how important their music career is to their mental well-being and doesn't tell them to just stop playing and do something else, to quote a phrase from a paper published by Alice Branfenbrenner. What we are asking is that healthcare professionals show that they understand the whole musician. Here we're talking about the whole body, strength, stability, and fitness, aspects of the sensory and motor control system like fine motor control, postural awareness, and hearing, as well as how the neurological system can change either with injury or rehabilitation. Mental focus, learning, and memory. Emotional aspects such as coping strategies and resilience. The musician's identity and the meaning of music to musicians, and the relationship between musician and instrument or voice. Finally, we feel that health professionals working with musicians should understand some aspect of how people's health beliefs, their motivation, sense of control over situations, personality, and habits influence their experiences of health challenges and their ability to prevent or meet those challenges. Not everyone needs to be an expert in all of these areas, but our recommendation is that everyone who works regularly with musicians does need to have a basic understanding of their importance, how these factors can influence our specific scope of professional practice, and when we should refer a musician to someone who can address what we can't.
All right, thank you, Christine. And now we're inviting Dr. Sajid Surve to the podium.
When I first started the Musicians Health Clinic at UNT over a decade ago, the College of Music sent a photographer to take promotional photos for our brochure. A young woman arrived with a camera and a bright smile, but what caught my eye was the brace on her thumb and wrist. Curious, I asked her about it. She told me that she had once been a master's student in clarinet performance, but she developed tendonitis in her right thumb. She decided to rest, saw an orthopedic surgeon about it, but the pain returned. She went back to the orthopedic surgeon. The surgeon gave her an injection, which helped temporarily, but then the tendonitis came back a third time. That's when he told her to stop playing the clarinet altogether and find a new line of work. Heartbroken, she dropped out of her program. After years of dedication, her dream was gone. The college needed a photographer, and since she had done photography as a hobby, she decided to take it as a new job. Now she traveled around capturing images of other people doing the very thing that she loved the most. As heartbreaking as this story is, it's not unique. I've heard it again and again. Musicians being let down by a healthcare system that doesn't understand them, or worse, doesn't value what they do. On behalf of that young woman and every musician who's been told to give up, we're here to say that enough is enough. Healthcare professionals must be equipped with the knowledge to recognize and treat the medical conditions that affect musical activities, from musculoskeletal injuries and neurological disorders to hearing loss, vocal strain, psychological stress, and the secondary effects of other health conditions. These are not niche problems. They are real, they are common, and they are preventable or manageable with the right care. Musicians are not just artists. They are athletes of precision, emotion, and endurance, and they deserve a healthcare system that sees them, understands them, and supports them. So here's the call to action. Let's adopt and implement the consensus statement on musicians' health. Let's ensure that every healthcare professional who works with musicians is trained to recognize the unique demands of musical activities and the conditions that come with it. This is more than a recommendation, it's a responsibility, because when we protect the health of musicians, we protect the music that moves the world. Now, let's hear item number 5 from Dr. Céleste Rousseau.
I would like to go further from what my colleague Sajid Surve just explained with both passion and lucidity. Protecting the health of musicians, protecting the music that moves the world, as Saj just said, is not only a matter of knowledge about the body, about injuries, about prevention. It is also, and probably more than anything, a matter of how we communicate with musicians, with our patients in general. Taking care of musicians, whether it is curative or preventive care, is a reciprocal learning process. We, healthcare professionals, will be learning all our lives from musicians as experts in their own performance, in their own craft. And of course, as health experts, we may sometimes have knowledge they do not have. This is a bilateral, profitable situation, teaching and learning at the same time. And this is also how we really can consider achieving the holy grail of the shared goal setting and of the therapeutic decision that really includes research evidence, clinicians' experience, and patients' choices and expectations. To ensure positive health outcomes, and therefore positive performance outcomes as well, we definitely need to take the appropriate time to ensure that we really understand our patients' objectives, which might be playing without pain, playing better, playing louder, playing longer standing rather than sitting, running with their guitar, headbanging, or whatever makes sense for them. This needs effective communication, using simple words when we provide health advice or convey health information, which might be complex. We need empathy, we need to reassure them, we need to support them, and definitely to pay attention to all the emotional cues we may catch with our ears, with our eyes, with our brains, with our hearts also, and even most of the time with the music itself. We have a lot to teach, but especially we have a lot to learn. And again, and this is how I personally feel about all of this work, research and clinical practice, our own way to make music is to support those who are playing, composing, and crafting music.
Thank you, Celeste. Next up is Dr. Aviva Wolff for item 6.
So item 6 is about caring for musicians. And when we think about caring for musicians, we think about it as a team sport. The demands of making music and the challenges that arise when injury or discomfort occurs rarely fit into a single discipline. So our consensus statement recommends that we foster teamwork and coordinated care across disciplines, making sure that healthcare providers, musicians, teachers, and instrument makers are all aligned. We, clinicians, engage with music educators, instrument technicians, and managers so that practice habits, setups, and daily routines can be optimized for both performance and health. We collaborate with other medical and therapeutic specialists to reduce risk and create personalized care plans. We build connections with institutions and performing arts organizations to promote access, prevention of injury, and early intervention. And we advocate for broader education and surveillance within the music community to recognize and mitigate performance-related conditions. In short, collaboration is the bridge between clinical knowledge and the lived experiences of musicians. By making collaboration a core competency, we create a culture of trust and empowerment, ensuring that every musician has access to the right care at the right time by a team that understands their world. We now invite Dr. Anke Steinmetz to the podium.
Thank you. When working with musicians in performing artist medicine, it's essential that healthcare professionals use focused and specialized clinical assessment skills. These help us to understand not just the musician's health problems, but how these are connected to their musical activity. So, what exactly do we need? First, good information history taking. We start by asking detailed questions, not just where does it hurt, but also what instrument do you play? How many hours do you practice? How does your practice routine and performance schedules look like? What symptoms are you having, and have you had this before? What treatments have you tried? This helps us to find patterns and spot risk profiles specific to the musician's routines. Second, early risk check, initial screening. It's absolutely necessary to look for early warning signs. This includes checking for muscle or nerve problems, balance issues, stress, hearing loss, or performance anxiety. For example, a trumpet player who feels dizzy on stage might need both physical and psychological screening. Third, detailed physical assessment, clinical evaluation. We do a full body check of the systems involved: muscles, nerves, coordination, and a pain assessment. We want to understand not just what's wrong, but how it affects the way they play. Fourth, watching them play. Activity analysis. One of the most important parts is seeing how the musician interacts with the instrument. We analyze posture, ergonomics, and movement. If needed, we use video or motion analysis. Collaboration with music teachers can also be very helpful here. For example, a percussionist might have great strength, but very poor posture when playing, which could lead to long-term injury. Fifth, thinking it through. Clinical reasoning. After gathering all this data, the use of critical thinking from thinking to form a diagnosis is necessary. If more tests are needed, like imaging or nerve studies, we have to arrange that. Then we start building a personalized treatment plan. Fix and last, keeping track, monitoring outcomes. Finally, we monitor progress. We do regular check-ins in person or via video to see how symptoms or function is improving. We adjust the treatment plan as needed, always involving the musician in the progress. In summary, treating musicians effectively means truly understanding the world. It's about combining medical skills with insight to the artistic practice and creating a tailored plan that supports both health and performance. Next, I like to invite Dr. Yein to the podium.
You're still with us? Thank you. Thank you for your attention. So I think what I'm going to say for my item number is rather repetitive. So I'm going to tell you a clinical story to help you talk about the item number 8. A few years ago, I met a clarinetist in the middle of our DMA, a really beautiful musician, but she had been having a lot of thumb pain, right thumb pain, so you take care of a clarinet player. That's a rather common problem. She went to see an orthopedic surgeon, sort of a similar story. The x-ray was normal. You have no problem in your thumb. Stop playing for a while. She stopped playing for a while, started playing again, started to hurt more. When she came to our clinic, it sort of follows through the item number 8 quite a bit, because we looked at not just her thumb, we looked at her whole world. We spoke with her professor, who agreed to reduce her performance load. Her professor even allowed her to perform her recital sitting down so that she can put her instrument in between her knees when she has a brief moment to rest. While she didn't have significant tendinitis or arthritis, we evaluated that in our office with our imaging, including ultrasound imaging. We realized that she has significant joint hypermobility from watching her play. So we referred her to an occupational therapist who had previously worked with many other musicians with similar issues. While she was in rehab, we tried to curate a pain management program that was comprehensive. So NSAIDs, maybe topicals, distractors, injections occasionally if she needed, and some manipulative treatments as well. And throughout that, she could play, and she was gradually recovering. We also found an instrument technician who was willing to work with us to determine if we can come up with a correct setup for her. Once her pain improved, we created a tailored return to play protocol so she would not re-injure herself as she slowly returned to playing full-time. During this time, we talked and coached her regarding her diet, nutrition, cross-training, managing stress, performance anxiety, and depression she suffered from due to this long-standing injury. So over time, with our comprehensive whole health model of care, she returned to doing what she loves, playing, teaching, performing on her feet. I just saw her last week, standing tall through her dress rehearsal. That was really awesome. But this didn't happen overnight. We really worked together as a team. Our goal should always be to care for the whole artist. We need to manage symptoms to reduce suffering and help musicians keep playing. We must also rehabilitate their functions so they can safely return to their art. Finally, preventing injury means supporting the entire musician, not just part that hurts, but the person behind the instrument. So now I'm going to introduce Dr. LaRae Murray to the podium for the next.
Hi, everyone. I'm covering consensus item number 9, health, education, and empowerment skills. When I think about this item, I think of the people I know that could have benefited from this information before experiencing pain or injury. While I am now an occupational therapist, I was a self-proclaimed band geek in high school and college. I remember having conversations with a college friend who was a classical pianist about whether he should change majors because of an injury. At the time, I didn't know enough about anatomy to offer advice, now I teach it, but I could sense the anguish that decision was causing him, whether or not to give up his passion. I was also in the marching band for years, and so was my identical twin sister, who played, imagine this, the sousaphone. She, along with many of her section members, experienced arm and hand numbness from holding their heavy instrument on their shoulder. Her numbness sometimes flares up even 20 years later. Healthcare professionals can play a role in minimizing these negative experiences. We believe it is essential to equip musicians with the necessary knowledge to prevent injury and promote wellness and quality of life throughout their lifespan. We recommend that healthcare professionals demonstrate competence in delivering musician education in the following 5 areas. Number 1, injury prevention. This includes information related to posture, warm-up techniques, and ergonomics. Number 2, symptom self-management. Healthcare professionals should empower musicians to recognize and manage symptoms like pain and fatigue by providing them with education about pain, mental practice strategies, and modification of practice behaviors and daily activities. Number 3, general health information. Topics include nutrition, sleep, physical activity, consumption of alcohol, drugs, and caffeine, as well as balancing playing music with other healthy activities. Healthcare professionals should emphasize how these can impact healing and health over the lifespan. Number 4, health literacy promotion. This will empower musicians to better access and understand health information, enabling them to make informed decisions to maintain or improve their quality of life. Number 5, stress reduction education. Healthcare professionals should provide musicians with effective strategies to manage stress and performance-related pressures to support mental and physical well-being. Now I'd like to invite Dr. Anke Steinmetz back to the podium.
All right. When treating musicians, it's not just about tests, exercises, or diagnosis. A big part of what makes care effective is the attitude we bring. So musicians are unique. They live in a world full of emotion, of movement, repetition, and pressure, and they deserve care that respects that. So first, build trust and collaboration, empathy. When musicians feel respected and involved, they are more likely to trust us, and that trust, that's what improves outcomes. Care should feel like teamwork, not a top-down instruction list. Musicians often deal with pain, stress, and fear, not just about their health, but about their future performances and careers. Empathy means listening with compassion, understanding what music means to them, and acknowledging their worries, even if we can't solve everything immediately. For example, instead of saying, just stop playing for a month, we might say, I understand that's important for you. Let's find a way to reduce strain while keeping you active. That little shift can make a very big difference. Second, be curious and open. Respect their individuality. Musicians use their bodies in special ways, whether it's a violinist holding the violin for hours or a singer managing music, breath, and acting. We need to stay curious, ask, observe, and learn. Example, if a guitarist comes in with shoulder pain, don't just assume it's just too much practice. Ask, can you show me how you hold your guitar? What's your daily routine looks like? No two musicians are the same. A cellist in an orchestra and a touring DJ might both have back pain, but the causes, pressures, and needs should be totally different. That's why treatment should never be the one size fits all. Third, be aware of your biases. Sometimes we assume pain must be caused by music, but that's not always true. For example, a pianist who complains about back pain may reveal it's actually from heavy gardening on the weekends, not from playing. If we assume too quickly, we may treat him wrong. Be aware of you and our biases, helps us stay open and accurate. In summary, when we treat musicians, the right attitude, one that's curious, empathetic, open-minded, and free from assumptions, builds the foundation for real healing. Now I'm inviting again Dr. Shelly-Anne back to the podium.
Thank you, Anke. We're almost there. Hopefully you guys are still all here with us. So I'm presenting number 11. Professional healthcare institutions, organizations, associations should fall on musicians' healthcare, should establish measurable healthcare professional competencies based on evidence and consensus of all parties with a vested interest in musicians' health. We should change the wording up a little because when you say it, it's a really mouthful, and I was, running out of breath. So, as you've heard throughout the summit from experts in musicians' health, musicians face very distinct physical, psychological, and performance-related demands. Yet these needs are rarely addressed in standard healthcare education. Right now, there is no shared framework that defines what healthcare professionals should know or be able to do when caring for this population. Care is often inconsistent and depends heavily on an individual provider's past exposure to musicians, personal interest, or informal training. None of that is standardized. As we know, as we heard today, musicians definitely deserve better. If we want to raise the standard of care, this is the critical next step. We need a clinical competency framework that clearly defines the skills, knowledge, and attitudes required to deliver effective musician-centered care. This framework should include core competencies for all healthcare providers and discipline-specific competencies for those in areas like medicine, allied health, and mental health. To be relevant globally, it must reflect regional differences in healthcare systems, including mechanisms for continuous education updates, defining training levels, and offer ways to evaluate both education and practice. We recommend 4 actions to develop this framework. So first, to examine current clinical practice to identify strengths and gaps. Second, we have to engage musicians directly. Their voices must shape what competent care looks like. Third, we must prioritize musician-centered outcomes that reflect the realities of artistic work and performance. And finally, it's crucial to create progressive training pathways from entry-level certification to advanced specialization. This is how we move from fragmented ad hoc care to a global standard that is coordinated, evidence-informed, and tailored to the real needs of musicians. And it's how we advocate, not just for better care, but for healthier, longer, and more sustainable careers in music. So next, I'm inviting Dr. Ralph Manchester back to this podium. Thank you.
Performing arts medicine as a field has clearly grown and matured over the last 40 years, but we probably need to up our game if we want to move to the next level as a recognized group of experts in the care of musicians and other performing artists. Occupational medicine is a recognized medical specialty, and sports medicine is formally recognized by several medical specialties. Likewise, the American Board of Physical Therapy now offers residency training in sports physical therapy. Achieving formal designation as a subspecialty will benefit both the performing arts community and those of us who care for musicians, dancers, actors, and others. The PAMA certificate and the existing graduate degree programs both reflect the body of knowledge that has evolved over the last 4 decades, but they are not recognized by third-party payers in the United States or by the medical or performing arts communities at large. Just as occupational medicine covers a wide variety of jobs and work sites, and sports medicine is involved in multiple types of athletic endeavors, our field needs to set the standards of expertise in the care of performers who engage in diverse artistic disciplines and have highly specialized skills within each of those disciplines. We need to define and assemble the knowledge base for the entire field, but we can't do it all at once. We can make a strong argument that PAMA is in the best position to take the lead in promulgating the core competencies for healthcare professionals who are providing care for musicians. We can then use a similar approach to create a list of core competencies for other performing arts disciplines, collaborating with other performing arts healthcare organizations as opportunities arise. Obviously, the only organizations that can create medical subspecialty credentials that have meaning in the real world are the various specialty boards of each country. Ultimately, our goal is to have performing arts medicine subspecialty designations in multiple countries and numerous disciplines and specialties. However, to get things started, we might consider working with one specialty board in one country. It could be the American Board of Family Medicine, which already has a certificate of added qualifications in sports medicine, or we could work with a physical or occupational therapy group. A major issue to be addressed is whether completion of a formal fellowship program will be necessary, and if so, can someone who is already in practice be grandfathered in based on clinical experience and passing an examination? Accomplishing just this first step will take several years, but the long-term benefits will be significant, and achieving subsequent recognition from other specialties should then be easier. We will hear the next item from Dr. Hara Trouli via video.
Hello, I'm Dr. Hara Trouli. I work in the UK, both in clinical services for performers and also directing for the past 10 years an educational postgraduate program in performing arts medicine here at University College London. So, education must be the way. All of us working in healthcare have arrived here following programs of training that we planned and scheduled throughout our healthcare careers. Performing arts medicine, and specifically music medicine, requires similar programs offering knowledge and skills that will empower us to confidently assess, diagnose, and treat musicians. An evidence-based educational program in music medicine should offer extensive theoretical knowledge of the human body's application to an instrument or to voice production. Ergonomics, instrument mechanics and acoustics, hearing challenges, respiratory and vocal function, and of course mental and emotional challenges are the basis of this education. To further and to deepen this knowledge, we need additional practical elements such as internships, clinical observations, hands-on workshops, and, why not, virtual or simulated practice. Our education would be so much more relevant and meaningful if we added to our music medicine training opportunities for shadowing studio lessons and orchestra rehearsals, and engaging with what musicians say, experience, or even worry about. It would be hard to assume that we healthcare professionals from all different specialties and disciplines can ride this alone. We need continuing and well-structured interactions with musicians. We need strong routes of communication. We need to offer our professional knowledge to musicians and receive theirs. The aim is one, and it is the same for all: to understand and address the physical and mental demands of the musician in all their career stages and across the genres and social and cultural settings. Thank you.
And now I bring to you Dr. Rose Schmieg.
Thank you. The tertiary setting is a logical starting point for developing an accountability structure for the health and safety of musicians. PAMA and NASM have partnered in the past to create a document titled Information and Recommendations for Administrators and Faculty in Schools of Music. It covers risk factors and neuromusculoskeletal issues affecting the body and voice. Basic recommendations are provided to avoid playing or singing-related injury. The document is a foundational piece of work that brings awareness of the need for structure focusing on performer health. It states that music administrators in higher education address policy, management, and evaluation issues. As a groundbreaking document, it arrived with disclaimers, however, which include, but are not limited to, the information is generic, presentational, and advisory in character, does not serve as the basis for the accreditation function of NASM. Perhaps its biggest shortcoming, and I quote, health and safety depend in large part on the personal decisions of informed individuals. Institutions have health and safety responsibilities, but fulfillment of these responsibilities cannot and will not ensure any specific individual's health and safety. Ladies and gentlemen, we are here at this summit to raise the bar at this time. If tertiary performing artists were treated like their athlete counterparts, as an example in the USA, we would follow the NCAA Sports Medicine Administration Handbook. It distinguishes what is a must-do from what is a should-do. Examples from it include athletes must have medical clearance to participate, including a pre-participation exam that would unearth injury risk factors. Athletes must sign an informed consent form where we explain to them the risks specific to each sport. Imagine if we explain the risks specific to each instrument and hearing loss and so on. Imagine this for schools of music. Safety in intercollegiate sports can only be attained by appropriate planning for and supervision of practice and competition. Student athletes should be informed what equipment is mandatory and what constitutes illegal equipment. Equipment should come from manufacturers with known safety standards. It is our time to develop a Performing Arts Medicine Administration handbook that has teeth, as does the NCAA's. We must work to define who is the governing body to manage it. University administrators should brace its primary goal of promoting musician safety while secondarily minimizing liability and risk to the institution. When greater than 50% of NASM accreditations would follow such a proposed handbook, its practices could then become the standard of care by which each program and its healthcare team are held accountable. If this new governance structure takes hold, it can then lead to changes that trickle down into secondary and middle school settings. That then in turn can lead to legislative initiatives, as we have seen in sports medicine, such as concussion, which was indeed a public health epidemic in sports medicine. And ultimately, this could impact positively recreational and other settings for musicians. Thank you, and I'd now like to invite, I'd now like to invite Dr. Zafar Zafari for item 15, which is the closer, as we'd say in baseball. Thanks.
Okay. So we talk about models of care that are the core engine behind how we support musicians' health. As a health economist, I'm always investigating what the options are and what works for whom and at what cost. In healthcare, we often use models like multidisciplinary, interdisciplinary, and transdisciplinary care. These sounds like technical words, but they really just describe how different professions like doctors, psychologists, physiotherapists, educators, and retraining specialists work together and share their knowledge and skills to make a joint optimal decision. The truth is, we don't yet know which model is the most effective for musicians. And more importantly, we don't know what outcomes these models actually improve. Is it less pain, more performance and stamina, or lower dropout from training programs? The first step here is evidence. We need to critically assess what models are already out there, how effective they are, and what outcomes they improve. Do they actually improve outcomes that matter to musicians? And a more important question is, for me, is whether these models are cost effective and are they sustainable? It is of note that healthcare practice and care delivery models are not the same everywhere. A classical or jazz musician in rural Europe has a very different care path than a conservatory student in Berlin. So our models of care must be flexible, context-specific, and inclusive of different access points to care. Therefore, to address such a multifaceted issue, it's necessary to build collaborative care teams that include not just clinicians, but also instrument-specific specialists who are professionally trained and familiar with the mechanics of a particular instrument. For example, guitar, trumpet, or violin posture. The inclusion of instrument-specific specialists will further improve outcomes that are more meaningful for musicians of that particular instrument. Finally, once these models of care are proved to be effective, we need to ensure they are implemented, evaluated continuously, and improved over time. We need models that adapt, not just launch and fade. So we need more evidence to generate and demonstrate what care models are most effective and cost-effective, and collaborate with different related professions to provide the most optimal care and support musicians' health. Now back to Dr. Shelly-Anne Lee.
Thank you, Zafar. So now that you've heard from many of the global experts in musicians' health on why each of these competencies matters, let's take a quick look at how our expert panel responded in round 1 of the Delphi study. So we've had 57 experts to participate, representing a wide range of disciplines and regions. The results were incredibly encouraging. All 15 competencies reached at least 90% consensus, meaning 90% or more of the experts agreed or strongly agreed that each item should be included as core competency in the healthcare of musicians with MSK and neurological conditions. And you can see here 98% average agreement, and specifically 93% average consensus for all items. So we have very strong agreement. So these numbers reflect a strong, unified commitment to improving the standard of care of musicians. They show us that this work resonates deeply across the field and that there's broad global support for moving this forward. So now I'm going to invite Dr. Bastepe-Gray, our chair, to join me in the conclusion remarks.
Thank you, Dr. Lee.
I'm always struggling with this. There we go.
Okay, all right. So thank you for tuning into this body of work co-created by over 100 musicians and health experts from around the world. From the results of both Delphi rounds, it's clear we have strong global consensus on the outcomes research priority items, the core competencies, and institutional and organizational responsibilities. We're now preparing to move forward with the remaining 2 rounds of the Delphi process for both studies, and we're truly excited about the possibilities ahead, especially how we will bring these consensus items to life in practice.
Now that we've reached global consensus, the next step is implementation, and this is where your leadership is essential. We're inviting all of you, experts from across disciplines and regions, to help shape how these research priorities and competencies are integrated into the real world. That means embedding them into research agendas, educational programs, clinical training, certification pathways, and day-to-day practice in your institutions and communities. Implementation doesn't happen in isolation. It takes a shared vision, collaboration, and creativity, and this group is uniquely positioned to lead that work. We look forward to co-developing strategies together, planning for feasibility, defining operational steps, and identifying where and how these consensus items can be modified and mobilized effectively. Together, we can take these ideas off the page and into the systems that shape musicians' health. Let's take these priorities and competencies not just aspirational, but actionable.
And thank you again. On behalf of myself and the co-chairs of the Peacock Group, I want to express our gratitude to all of our speakers today who made the special trip to come and join us on stage. And our steering committee and all of the global experts who generously shared their time, insights, and expertise. Through your comments and ongoing dialogue, it's clear your passion and commitment to transforming the landscape of musicians' health is unwavering. Your engagement in shaping these consensus items reflects not only deep knowledge, but a true dedication to this field. Our collective voice reflects the very spirit of this global summit: advocacy, collaboration, and action. What we've shared here today is just the beginning. We're excited to move forward with you in the planning and implementation phase, and we invite each of you to continue this journey with us. This is our moment to raise the global standard of care for musicians. Let's begin building that future together. Thank you.